A finger exam, just visual inspection, looking for any swelling or rotational deformity. Check the cap refill. Always check pulses. And then I always have the patients put their hands out and I say, okay, tell me if this feels the same or different. And you just check median nerve, radial, and then ulnar, and do both surfaces. Make sure they have good range of motion in their wrists, good. And then this way, awesome. Can you make a fist? Usually if there's a finger fracture and you ask them to make a fist, they're gonna kind of do this, they're gonna go, oh, I can't. Really important though, when you're looking at fingers, when you have them flex and they're gonna say, well, I really don't wanna bend it, they need to bend it because sometimes, I actually have fractured that one, you see how it's a little crooked. You won't see the rotational deformity until they flex. When they're out straight, you may not see it. So that's important in your decision making, is it rotated? Because if it's not, you may just splint it and say follow up with your primary care. If it's rotated, they may need to see ortho and get that. They'll usually put K-wires in it. Fingers, they don't stay. If it's rotated and you try to reduce it, it's gonna go back to rotation. So they've got to usually put K-wires in there, Kirschner wires to fix them. So I'm looking at flexion, extension, and then if it's, I don't do manual motion testing of all the fingers, if it's their index, I'm gonna check motion, and if there's an obvious fracture, I don't go crazy on, I don't go crazy on checking the ligaments if there's an obvious fracture on my x-ray, but if I'm not sure and they think maybe they dislocated, that's when you're gonna do your stress testing of the ligaments. So you kind of put your thumbs here, and you're gonna give that a nice stress, and you go this way. Same thing with DIP joint. If you're checking PIP motion, just kind of stabilize that. Can you flex your finger for me? Good, hold that real hard, hold it. Good, now bring it up and don't let me push you down. And you can do the same thing in DIP. So flex this down, good, and then push up. And you can document profundus and superficial, remember the whole thenar and hypothenar, you're checking that. After that, I pretty much go into my special tests. So we talked about the cascade. Remember how your fingers go towards that scaphoid tuberosity? So they don't go like this, they normal cascade. Opposition, so can you touch? Yep, go through all your fingers. Good, and I always ask them if they can touch their thumb on that pad, and if they've hurt their thumb, they have a hard time with that, usually. And we talked about the ligamentous stability. We'll talk about, just real quick, on skier's thumb. Come around here, Yvonne, I wanna show this. This is really important. So this is the patient that got their thumb caught making a tackle. Real tender over this side, so you're palpating there. Yeah, that's where my pain is. You hold the metacarpal like this, real firm, hold the proximal phalanx here. You're putting these two index fingers on this side, because that's where you're gonna pry against, and you just apply a stress like that.
And you gotta test the good side first,
yeah,
because it's hard to understand it until.
Well, let me see if you have any laxity in your thumb here. Maybe a little bit. So she's an athlete. She probably sprained this thumb at some point, and it does have a little more play in it. See that? It has a really firm end point though. When I get to there, it's just stuck, and that's important. So that's my ulnar collateral, and then the radial collateral is this way.
Okay.
So you just do them both. Yeah, that's definitely more stable. Huh. So, but that's an example. A grade 1 tear or sprain, still pretty intact, not much laxity, put it in a splint. Grade 2s and 3s probably need to be fixed. So trigger finger, just, so we'll just kind of show on the hand. Trigger finger is gonna happen at the A1 pulley, which is right about here. You're gonna feel that little bump. Those patients are gonna say, my finger keeps getting stuck when I'm doing stuff and I can't get it to straighten out. And sometimes they have to take it and do this and it'll click and it'll straighten out. The flexor muscles are way stronger than the extensors, so they're always able to get it flexed. That area of swelling on the tendon can get past the pulley, and you can feel trigger finger. If you put your thumb on that area that's swollen, you'll feel it move up and down, that little bump as they're flexing. So that's kind of helps you diagnose it, because it'll move proximal as they flex and move distal as they extend. And it'll get past that pulley and they can't get it back. So that's what you see with trigger finger. Okay, so we're gonna move on to x-rays.